To answer, you all can enter. Yeah. Okay. Hello. Yeah. Am I audible, Akif?
Yes, Naveen, you're audible.
Yeah. So let this be an interactive session. We'll see. I'll go by the basics only because this is the last session what you all will find in your Viva exams. So already the examiners will be tired. Your long case will be over. I'll crisply ask you what generally examiners tend to find out easily on in neuroradiology. Okay. Yeah. So any volunteers? The more we discuss, the more we can learn. So this, yeah. Can you all identify what sequence is this? What image is this? What sort of a modality of imaging is this? Anyone volunteering? No. Try making mistakes. That's okay. Anyone available? Yeah. Okay. Uh, yeah, one of them answered. Someone texted me. Yeah. Okay. So this is a CT. How can you make it out? It is a CT. You can see the dense bone, skull bone. You can see it. And what can you see inside the CT? The some hyperdensity inside. Yeah. There is left hyperdense MCA. Yeah, this is an early sign of a stroke. So a hyperdense MCA is an indication for thrombolysis if patient is coming within window period. Okay. And if it, yeah. So when do you see bilateral hyperdense MCAs? That's the question. You see bilateral hyperdense MCAs in conditions like slow flow, which is associated with polycythemia. So this is a CT brain showing a hyperdense MCA sign. Yeah. And is a sign for acute stroke. So let's go for the next one. Yeah. So what is this? Yeah. This is a little tougher one. If you answer the first one, they'll give you the next one, which is a little bit tough. So here you see that the insula. What is insula? The innermost zone where you see that it is lost. The contour is lost. So this is the loss of insular ribbon sign. On the right side, that is CT, your left side, that is CT brain when you are seeing in the anatomical right. There is the ribbon which is in intact position. Whereas on the left side, you see that is there is loss of insula. So this is also one of the sign for acute stroke. So as general medicine residents, you all tend to see more of stroke patients, pneumonia patients, and renal failure patients. So stroke presents with these two signs mainly, MCA sign, which is dense MCA sign, acute ischemic stroke, and this is loss of insular ribbon sign. Okay. Yeah. So what is this? Is this a CT image or an MRI image? Mm-hmm. Yeah, you all can participate. Okay. So this is what shape is this? Does it look like a banana or does it look like a pie? So pie spells PIE. So banana, this is biconvex. Okay. So what is this? Okay. Intracranial hemorrhage. Okay. What sort of intracranial hemorrhage? Mm-hmm. Yeah. Okay. So is this SDH or is it EDH? Is it subdural hemorrhage or is it extradural hemorrhage? So when you see a biconvex, it is extradural hematoma. Okay. Yeah. On the contrary, what is this? You see a convexo concave CT brain. Yeah. One is hyperdense and the other is hypodense. What difference does it make? So one is an early subdural hemorrhage, that is a normal subdural hemorrhage, and the other one is a chronic subdural hemorrhage, where the blood has turned itself, the hemoglobin degrades, it becomes hemosiderin in the last, and that turns into a hypodense structure, and that is chronic SDH. What you see on your right is chronic SDH. What you see on your left is acute SDH. So you see that is SDH, which is significant enough to cause a midline shift. You see the ventricle which is being pushed towards the left side. Yeah, so that is called midline shift. So midline shift is important to determine whether patient needs surgery or not. Greater than 5 mm is significant enough. Okay. Yeah. So we'll see what are the differences between extracranial, epidural hemorrhage, hematoma, and a subdural hemorrhage in the subsequent slide. Yeah. So EDH, generally the origin is MMA, and SDH, it's the bridging cortical veins. Okay. And lucid interval generally is present in EDH. Okay. What's the catching point here is the shape. It's biconvex in EDH and concavo-convex, that is crescent shape in, yeah, crescent or banana shaped in SDH. Yeah. And what tends to be more dangerous? EDH is more dangerous because it tends to rapidly progress and surgery is almost always required. And you have a limitation by the sutures in ADH, whereas you don't have limitations with SDH because it is a dural folds inside. Yeah, next is this. If you are in a good setup, generally DNBs tend to be in a good setups, like where MR imaging is available. So what is this? Okay, this is circulation of brain. That's good. Okay, this is an angiogram. Very good. Okay, what do you see? What sprain is applied by? Yeah, it is applied by the ICA and the vertebral arteries. Yeah, so do you see the ICA? Yeah, you see it. You see that curvy structure which is present there? That is the ICA, and it is giving away its branches. What are the branches of ICA? Yeah, main branches are the MCA, okay, and the ACE, okay. Yeah. So what is the posterior circulation? You have two vertebral arteries and they two join to form a basilar. Wait. Where is the basilar here? Is there a basilar? No, yeah, this is basilar artery thrombosis. Okay, this is a MR angiogram of a basilar artery thrombosis. You can't see a basilar artery here. So what happens? The posterior circulation gets infarcted. So what happens when posterior circulation gets infarcted? You see a CT like this. So sometimes when you see a small dot in front of your brainstem, don't tend to think it is a calcification. It can be a basilar artery thrombosis, which can eventually turn up like this. Towards your right, you see the intense edema, which is seen in a basilar artery thrombosis patient, which mainly supplies the brainstem and the posterior part. That is the occipital region and the thalamus. Okay, one more common emergencies which you all face, especially general medicine residents. I'll give you all history for this case. This is a 56-year-old chronic alcoholic who has come and he has been he has this patient has been to Goa and he presented also with Goa. What is Goa? Yeah, he presented with ophthalmoplegia, ataxia, and confusion. That is global confusion, GOA. Global confusion, ophthalmoplegia, and ataxia. What is this? Yeah, when you all heard the code, you all answer this. But what is this finding? Very good. Excellent. Wernicke's. Okay, what does a red arrow point out to? What does a red arrow point out to? Yeah, there's a yellow arrow and a red arrow. And you can see this is a flare image, which is hyper intense. It is showing some hyper intensities. Okay, I'll give you all a clue. It is a body which is linked to something famous in Egypt. Mammillary bodies. Yeah, that's a correct answer. Yeah. Okay. And what you see with the yellow arrow? Yeah, that is the periaqueductal matter, which is showing a hyperintense signal. Yeah. So this is Wernicke's. Very nice. Okay. Okay. Here I've given the clue also. What is this? This also general medicine candidates tend to treat in some places. When you're on night duty, you'll get to see someone with hyponatremia and you'll aggressively correct it.
Central pontile myelinosis.
Yeah, osmotic demyelination syndrome or CPM. And what sign is this? So this is one of the most debilitating, what do you call, after effect of aggressively correcting sodium. Patient will be in locked in state for life. So when you study about correcting, yeah, someone is answering. That's good. Yeah. Okay. So this is osmotic demyelination syndrome related sign, which is known as a trident sign, where you see a trident-like structure in the pons. Okay. It's also known as a piglet sign. Okay. Yeah. Because medicine examiners generally tend to ask you all what you all see in and out. So it is what is the bread and butter? Stroke, dyselectrolytemia, and some syndromes and some infections. So they don't generally cross all that. Okay. Hmm. And what is this? This is a
Pneumocystis.
very good. And what sign is this called?
Mhm. I don't know.
Okay, I'll give you all a clue. It's a very active volcano in Japan. Mount Fuji sign.
Mount
Generally,
Fuji.
when you see there is pneumocephalus and there is neat cut delineation of the cortex near the frontal region, you call it as a Mount Fuji sign. Okay, this is pneumocephalus. If it is causing tension, generally conservative management is seen for pneumocephalus, but if it is causing raised ICT and other features, then we need to do some intervention. Yeah. Okay. So now since we already talk about electrometabolic components, we already talked about, wait, my image is not visible, right? Yeah. We talked about metabolic components. We talked about acute ischemic stroke. We talk about, now we switch to infections. Yeah. Why
Neurostitis.
is it neurocystic sarcosis? Because there are multiple small
Ring enhancing lesion.
ring enhancing lesions. Is this, what image is this? Because you are saying it is enhancing. It is a T1
Enhancing
image.
contrast.
Yeah. Yeah. It is contrast, which is enhancing. These are ring enhancing lesions. So what is the staging of neurocysticercosis? Anyone who can name it? Neurocysticercosis staging. I'll give you all 1 minute because this is important. MCQ, I mean, yeah, medicine, my old examiners, they are very interested in this. Anyone? So I'll give you a clue. The first one starts with V. Okay. Vesicular, colloidal, granular, and nodular. Okay. Vesicular, colloidal, granular, and nodular or calcified. The last one is calcified. Okay. Yeah. Okay. So what is this? If you all are in a government setup, you all tend to be the center for retroviral patients. This is a HIV
Tuberculoma.
patient.
Tuberculoma.
Tuberculoma, generally, you see a target here, no? It
Yes,
is a
sir.
target and a target within a target. So
Toxoplasmosis.
yeah, toxoplasmosis. This is a toxoplasmosis related eccentric ring sign seen in HIV patients. And now they ask you How do you treat the patient? Can you treat? They ask you what's the primary host here, and they'll ask you what level of CD4 count is important for this. So toxo, exo. Exo is 100. So if it is less than 100, people generally tend to develop toxoplasmosis in this. Okay. And yeah, this I wanted to just put it for y'all because this would be the basic question by majority of the examiners. They'll ask you how would you identify the sequences. So straight funda, remember World War II. Okay. World War II. That is water is white in T2. That's it. Okay. And how would our MBBS subjects be? In first year MBBS, everybody would be good. In second year MBBS, then turn all your friends will become the opposite, right? So T1 is our first year MBBS. Gray will be gray, white will be white. So you all know gray matter is in the cerebrum is outside and white matter is inside. So gray will be gray and white will be white. There'll be no shades in our first year of MBBS. But once we pass that anatomy and anatomy and physiology, our shades change. So gray will the outer matter, gray matter will become whiter and whiter matter become gray in T2. So it is the opposite of T1 in T2. And what is flare? Flare is nothing but it's a blend of T2. That's why I placed T2 and flare besides each of them. So if the water in T2, that is white structure in T2 is suppressed, what is water in the brain? It is a CSF. So if you suppress the CSF in T2, it is flare. Okay. And why do you use flare? You look for edema because edema is not CSF. Only CSF range will be suppressed by flare. So if you see lots of flare hyperintensities, it is edema. Okay. So T2 and flare are friends and T1 and contrast are friends. Okay. Sir, how do I make out a T1 and T2 other than gray and white matter? You can also look in for the fat in the scalp. Okay. It will be more bright in T1 and less bright in T2. Okay. So this is a proforma. Is the CSF white? Yes. Directly go into the T2. If it is no, then think about the gray matter, which is darker than white matter. If it is not darker than white matter, then it is flare. If it is gray matter is darker than white matter, it is T1 of T1 contrast. Okay. Yeah. Okay. And yeah, what would this be? This I added just to ask you all about the questions related to edema. They'll give you some image related to CT and MRI and ask you about edema. And this is vasogenic edema because of a glioma in an MRI. Okay. This is an MRI. What sequence is this? You can see T1, you can see a contrast T1, and you can see flare. Okay. So this is a glioma showing intense edema. That is in the flare, you can see lots of edema. And they'll ask you what are types of edema and anti-edema measures because everyone's favorite of the older generation is mannitol. And they'll ask you side effects of mannitol. They'll ask you when would you give dexamethasone because these are the anti-edema drugs which you all know, right? So you give dexamethasone for space-occupying lesions because they cause vasogenic edema. And when there is cytotoxic edema, you tend to give an osmolar hyperosmolar agent, which is hypertonic saline or mannitol. So when there is an SOL, you give dexamethasone. That is to decrease the vasogenic edema. So it is vasogenic edema, cytotoxic edema, interstitial edema. And now there's a new classification where there are four, or there's another type of edema, but that's not needed. Okay. So what is this? Anyone can answer?
Meningioma.
Yeah, it's a meningioma, but what sign is this?
Mhm.
Our favorite cartoon.
Poppy signs.
Mm. Mouse, dural tail sign or the
What
mouse
the
sign. Yeah, this is important because they'll ask you. Some opponents, examiners are favorites. So make sure you know what is a dural tail sign. You can see the dura, which is being tail-like, tapering towards its end because this is a arising from the branches. Okay, this is a branch. Okay, these are the main things which I wanted to convey. They tend, y'all will be very good with tuberculoma. That's the reason I kept only NCC here. So brushing up everything in this 30 minutes, what we came across is whatever is in stroke, whatever is metabolic, and the rest of those hummingbird signs and all those they don't generally ask in DNB or MD exams. If at all you want to be like, if you want to be, if you want a crack distinction and all, make sure you'll know what is Mickey Mouse sign, what is hummingbird sign, and what is hot cross bun sign. Other than that, I don't think so. They'll go deeper. Okay, and identify the sequences properly. Know this. If you learn even the staging of bleeding, that's good. That is, how do you stage a bleed in an MRI? Like if you see a T1 isointense signal, what will happen? If you see a T2 hyperintense signal, what will happen? That also is an important question. If you all want to learn, you all can learn. I hope this session was useful.
Yes, sir.
Okay. Yeah, okay. Right.
Yeah, Naveen, thank you. Thank you very much for your time. Anybody
Okay.
has any questions, they can ask.
Yeah. Okay. There'll be a YouTube link for this. You all can post your questions there also. Make sure you all are confident in identifying whether it's a CT and MRI. When you'll answer the examiners, go step by step. Don't directly jump into a conclusion. Okay. Thank you.
Yeah, thank you, everyone.
Okay. Yeah.